Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Hello, this is Jason Edwards, and this is Doc Discussions. I'm here with my friend Dr. Julie Gould. She's an OB-GYN. Julie, how you doing today?
I am fantastic. Thank you.
Yeah, welcome. And so tell us a little bit about yourself. Where are you from originally?
Oh, well, that might take your whole podcast. I'm actually from the West Coast. I'm from the Bay Area. San Jose is where I lived till I was about 13. Then moved to Northern Nevada, where I went to high school and undergrad. And then actually residency is what brought me out to St. Louis. Okay. And I never thought in a million years I'd be like, yes, I want to live in St. Louis. But I actually ranked, it was St. John's Mercy at the time. I ranked them number one for my residency and got it. And then just had wonderful experience there for residency, met some great people, and then we decided to stay here. So yeah,
so Mercy's residency program, it's what they call a community program,
yes.
Right?
Mm-hmm.
But it's a very highly sought after residency program.
Yes.
And especially these days, I think as residents or potential residents care more about quality of life, I think it's only gotten stronger. And so it's attracted a lot of good talent to the city.
Yeah. What brought me there is, so I had the best advice I ever had from an OB-GYN resident out of the University of Iowa. He said, do not go to a program that has fellows. And I was like, What do you mean by that? He goes, because you're never going to get to operate. He goes, go to a community program, you get to assist on all the surgeries. So, and that was very true. Like at a time where like I got out of residency with like 107 vaginal hysterectomies. And then one of our big powerhouse residencies in town, they were on probation because their residents were only doing 7 vaginal hysterectomies. So I feel very blessed that I got to operate so much as a resident over there.
Yeah, actually, in part of my training, there was a resident in general surgery from a community program, and he came in for his last year. And the attendings just treated him like an attending. He got so much respect, and he was treated totally differently than the residents just because he had done so many more cases and was so capable.
Right.
And so, there's definitely huge benefits from a program like that. Right. And so now you're at St. Luke's.
Yes, which I love. And I have a hard time going back to Mercy now, though, because I love the community feel of this hospital, though, too. And we know I know everybody here. I know, who I like for general surgery and urology, and I could get, cases on when I want to. So I've been here, since 2010, and I'm very thankful and appreciative to St. Luke's for helping me stay here, though, too.
But a lot of OB-GYNs have privileges at other hospitals, right?
Yes, yeah.
And so you work some at Mercy, is that right?
Yeah, I still deliver at Mercy, and I have privileges to do just to do GYN surgery, but I hardly ever go there. Same thing with Missouri Baptist. We can deliver there, but we do it more for insurance reasons, or sometimes if there's like high risk reasons that somebody has to go to a certain facility for the mom or for the baby.
Yeah. And I think you probably work with my wife to a small degree from time to time.
Yeah. I definitely have consulted your wife. She's fantastic too.
Oh, thank you. And so now an OB-GYN practice can be more obstetrics or more gynecology.
Yes.
What's the breakup of yours?
Oh, well, that is changing now over the years because as I age, my population is aging with me now too. So I used to be really OB heavy. Now, like I talk about hormones quite a bit during the day. So, I'd probably say that I'm actually probably 50-50 now, which is different than where I was 10 years ago, where it was probably heavier in OB. But like I said, as all my population is aging with me, we all have the same problems. Yeah. And that's the thing that we've realized, though, too, that as women, we talk and when we don't feel good, like we all start talking. So, one of my friends talks to another one of her friends and they hear like I do, hormone replacement therapy, where not all GYNs will do hormone replacement therapy. They'll farm it out to boutique practices or people that just want to do hormones all day long.
Got you.
But I feel like most of my new patients coming in are coming in because that's what they want, though.
And so, let's get into that. So why would somebody want to have hormone replacement therapy? What are like the main symptoms that they're trying to address?
Right. So, well, this is going to surprise you. The number one complaint coming into the OB-GYN office is not my cycles are irregular or I'm having problems with my discharge or I have hot flashes. It's I'm gaining weight in the midsection. Like universally, I probably hear that about 15 times a day. Like, I don't know why I'm gaining weight in the midsection. So, and there's a lot that goes into that, more so than just hormones, but that's the number one complaint coming in. But the other things that people will complain about, I mean, and it's like a whole myriad of potential symptoms that people have, but the most common are like hot flashes, vaginal dryness. I don't want to have sex with my husband anymore. Can you make me have a libido? Like that's a huge, huge one though too. And then there's other stuff that like I hear, but not quite as frequently though too. General joint aches, dry eyes, skin changes. People are always very worried about skin changes. And then there's some people that are just very proactive with their health though too. And they, they've read the books and they've listened to the podcasts and they know that like estrogen does confer health benefits in the sense that it, helps reduce cardiovascular disease in the first 5 years out from menopause. It will have bone protection. It protects your vagina, protects your bladder. There's so much good that estrogen actually does that some people are just proactive coming in because they're like, look, I want this for longevity. I want this for, for my brain health, my cognition. And that's why some people come in. But yeah. But it's, it's usually not one thing. It's several things at one time.
And it tends to help with all of those things, correct?
Yes. Yeah. And different hormones will help with different things. So we just really break down what we offer them according to their health history. Do they have a uterus? What is the worst of their symptoms and start from there.
And so now some of the things that, make oncologists nervous, especially, probably more so in the past, are the risks with cancer.
Right.
Can you speak to that a little bit?
They have really walked that back, actually, since the Women's Health Initiative was done. And that was initially the big study that was done that scared everybody off from hormones. And since that time, I don't feel like as far as clinicians go, we have caught up with what the literature actually shows. North American Menopausal Society will say that we do not think that hormones causes cancer. But would I give it to somebody that has a tremendous family history of breast cancer, or would I give it to somebody with breast cancer? No, I wouldn't. So we do have to, still do a very in-depth family history, in-depth personal history before we decide what it is that we're doing. But even with the Women's Health Initiative study, they did show that women that received estrogen alone actually had less cases of breast cancer than women that did not have anything at all. And then the other flaw of that study was that in the estrogen and progesterone arm of that study, they used a progesterone called medroxyprogesterone acetate. And so with that, once they added that progesterone to the estrogen, they did have what they thought was clinical significance of increasing breast cancer. So what I always tell my patients is if 1 in 8 women get breast cancer in their lifetime, they thought 1 in 7.9 would get it if you were on those particular kinds of hormones. But what they never really went back and studied was do we think it was the medroxyprogesterone acetate, which is Provera? Do we think that actually could have been the culprit? And nobody ever did the study afterwards. So nobody really uses that hormone anymore for the progesterone aspect of their hormone replacement therapy. We all use micronized progesterone, which is Prometrium. So
so emerging data looks like it's a lot safer and maybe doesn't even contribute to it.
Correct.
Every patient. So there's plenty of people out there who take supplemental estrogen or estrogen and progesterone, a combination. Yes. And every patient that I've ever had who's had that, who ends up having a breast cancer,
right,
attributes it to the estrogen.
Right.
And, when, if it does have an effect, it's just a fraction of those patients who would be affected by it. But you can't get it out of their mind. They say the estrogen caused this.
Right.
And good luck trying to convince them otherwise.
And I don't try to, when people come into my office, I do not try to talk them out of that thought.
I don't either, even though statistically it's unlikely.
Right.
You just can't. People have this anchoring bias. It's the first thing they hear or the first thing they think.
Right.
And For what it's worth, I've never had a patient who was on supplemental estrogen who had a breast cancer that ended up being anything but like a very favorable T1A or T1B,
Right.
ERPR positive, HER2 negative, like the most favorable, most curable cancer.
Right.
And in my estimation, their overall quality of life, despite having a breast cancer, as horrible as that is, it was probably still better from being on the hormone. And I'm probably
Right.
I feel like I'm probably in the minority of oncologists who would say that.
I think it's starting to change, though.
Okay,
Actually,
good.
though, I feel like there's people that want studies to be done on people after breast cancer using hormone replacement therapy. Maybe not necessarily estradiol, but being able to use estriol. Because the fact of the matter is that for some people, when their estrogen goes away, they feel miserable, though.
No
and their
doubt.
quality of life really does suffer. So they really do come in going, what else can you offer me? What can you give me in the context of safety that's going to correct my hot flashes, that make me not feel crazy, that make it so like my vagina doesn't hurt all the time every time I try to have relations with my husband? So they are desperate coming in and they want something else, though, too.
Yeah.
And we do a lot. I do a lot of sending messages to the oncologist saying, this is what the patient would like. Do you feel comfortable with this, though, too?
Yeah.
And most of them do feel
Good.
comfortable with the basics that I'm asking for. And then there's some that, we kind of go, we might have to get a little more creative. So,
Yeah.
there is estriol that can be compounded for you. And that's, a whole different world. And some people, won't go into that world, but I like to give people all the options, though, too.
And the vaginal estrogen, the intravaginal estrogen, there doesn't look like there's any risk with that, correct?
Well,
as far as
it depends
cancer.
on what paper you actually read, though,
Okay.
too. But overall, we feel comfortable with the lack of systemic absorption. But there are some papers that say, like, oh, you might absorb a little bit. And the people that have like serious estrogen sensitive cancer, we tread lightly there. And we know which brands that we like to use that have less systemic absorption,
Yeah.
though, too. So
I've seen so there may be some absorption, but I've seen some pretty large studies that did not show any
Correct.
increase in incidence of actual cancer.
correct. And yes, yeah.
And so to me, the patients that I've seen on hormone replacement therapy, the women, it does seem like their quality of life is better than average. Now, tell me if I'm crazy. To me, they look better.
Yeah.
So I've done this more than once.
Right.
I've looked at a patient and I said, I bet she's on
Right.
estrogen replacement therapy to the nurse.
Oh, yeah.
And have nailed it. And it's not
Yeah.
that common.
Yeah.
And so, but to me, they have their skin looks better.
Yes.
I dare say they look prettier.
Right. And I don't know if it's because these are people that are proactive with their health, though, too.
Very well could be.
But there are some people. I mean, I have this beautiful 79-year-old that comes in. I'm like, I want to be her when I'm 79.
Yeah. That's who it is. It's the people who are like 70s or late 70s or 80s who look really good. Those tend to be the ones I'm like, I bet they're on hormone replacement.
And this lady always comes in. She's from California, gives me her list of labs that she'd like to have done. And she knows exactly what she wants when she comes in, though, too. But I mean, she looks fabulous, though, too. And she's very lively, though, too. And so, so I agree that you could tell the people that are still on hormones. And yeah, I 100% agree.
Yeah, I don't know if there's any research on that, but it's like a je ne sais quoi.
Clinical observation.
Yeah, but it seems kind of obvious when you see it.
Right, yeah.
And now, how can the estrogen be given? Is it a pill, an infusion?
Yeah, so there's a lot of different ways. And I think there's like 26 different formulations of ways that you can give.
Really?
Yeah, something crazy like that.
What are the main ones?
So, I mean, most people's go-to, or at least my go-to, is probably starting with a patch. And the reason for that is because transdermal estrogen actually does have less risk than taking oral estrogen. So it bypasses it bypasses the first pass system. Am I saying that right? Where it doesn't go through the liver. So it doesn't affect the coagulation cascade as much. Yeah. And there was actually this great article that came out in the British Journal of Medicine in the last year that looked at cardiovascular risks associated with taking estrogen in different routes. And they did not show any risk in DVTs or blood clots in the arm that had transdermal estrogen. So the people that used a patch had no increased risk.
Okay.
So in general, we try to use a patch. I often use gels also, though, too, but gels are just not covered as well from insurance. And knowing that there's all these different all these different ways of giving it and different brands that are available, people always come in and they're like, well, I want to use this. I'm like, I'll write it for you, but it's going to cost you $300, because your insurance is not going to cover it. But they usually cover a patch to start with. Okay. And there's some people patches they just don't stick to, or they don't like using the daily gel. And we will use oral, though, too. And oral estradiol is dirt cheap. So for some people, they're like, that's what fits in my life. I'm going to use an oral estradiol instead.
Yeah.
But then there's also vaginal rings. There's actually a ring called FemRing, which I'm always learning things every day I'm learning new things. But there's one called FemRing that you could insert vaginally. And of course, it helps with vaginal atrophy, pain with intercourse, but it is absorbed systemically, whereas a lot of the other rings are not. So you could get systemic absorption of estrogen through this ring, which is awesome, though, too.
Is that uncomfortable? Do people think
No, you don't even. That's also like every time somebody comes in and I show them a ring and go, and there's a ring, and they're like, ew. I'm like, it is seriously, you will not even notice it's there.
Okay.
And it's a great vehicle for providing medication, but I think people are just afraid of it. I just want everybody to try it and be like, look, you're not going to notice it's there. And then they're afraid they can't get it out, but it is very easy to get out, though, too.
Okay.
But I mean, there's shots, there's pellets. Pellets is like its own conversation that is its own podcast, but there's pellets that a lot of people get. But yeah, there's several different ways to give estrogen. Some are in combo patches, some are in combo pills, but yeah, lots of different ways.
Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Do you ever treat patients who are premenopausal?
Yeah, and that's a little bit harder, though, too. But
with insurance or with the patient, or harder how?
Because we're dealing with a cycle then. And and we definitely have people that are perimenopausal, and you could get these symptoms, 5, even 10 years before your last menstrual cycle actually occurs. Yeah. Because menopause is when you've gone a year without having a menstrual cycle.
What's the average age for that?
51.
51.
So yeah, so it could happen. It's considered normal anything after 40. So I have plenty of people that are 40, 42 coming in, and they're like, I just feel like it's coming. Like I'm getting the hot flashes. I can't sleep. And I didn't mention sleep enough. And sleep is actually probably one of the most important things to have addressed. But sleep is one of the first things that go, and it's not the ability to fall asleep, but it's the ability to stay asleep. Yeah. And that's what they'll mostly start coming in with is like, I can't sleep. I'm really hot. I'm waking up sweating. But they're still cycling, though, too. So you can't just really put a patch on them and then say, use progesterone every day, because your cycle is going to become a little more wonky then. Yeah. So that's where we get a little more creative. Sometimes I'll put people on progesterone for 3 weeks and off. Using a progesterone IUD, I love when patients have a progesterone IUD placed because it makes giving the estrogen that much easier, though, too. Okay. And they don't have the cycles that are all over the place then also.
That's interesting. Yeah, because typically you just think postmenopausal, then you go in and get it. But actually, I was discussing this with somebody before we did the podcast, and they were premenopausal, and they were saying, "What about before?" And so that's cool.
And sometimes we just put people on a low dose birth control pill, which is fine as long as people aren't smokers, as long as they don't have migraine with aura, as long as they don't have liver dysfunction. It's fine to put people on a low-dose pill. I mean, basically any birth control pill is considered low-dose now, but you could put anybody on a birth control pill to control their symptoms, though, too. Okay. And that's totally fine also. And sometimes it's easy.
So when I think of medical care, you're trying to increase the length of life or the quality of patients' lives. And it seems like, a lot of these are a significant increase in their quality of life. Yeah. Is there any data on what it does to length of life at all?
I don't know that. I don't know it off the top of my head. Yeah. But you're going to see it in different ways, meaning that, if you're on estrogen, your risk of hip fracture is going to decrease. Yeah.
That's related to length of life.
Right. So also, if your cardiovascular system is improved, then that's going to increase your length of life. It's going to reduce your risks of dementia, though, too, which is I feel like a really big deal, is to keep cardiovascular system in check for your brain health more than anything else, though, too.
100%.
So
women have dementia, I think, more than men, or Alzheimer's more than men. And then, one thing that's, to me, seems totally obvious is if you have plaque in your arteries of your heart, you probably have plaque in the arteries of your brain.
Yes.
And a lot of dementia is vascular dementia.
Right.
And so, and if you feel better, if you're have less psychologically, you're doing better.
Right.
Physically, you feel stronger. You'll probably be more active. And so now it's a hard study to do, because it takes a long time to see who lives longer.
Right.
And there's a lot of selection bias.
Correct.
And that, it would probably be a healthier person who would initially, try this, or, on average, a more educated person who just knows it exists.
Right. There is so much room for studies to be done in the future, though, too. And the studies that have been done in the past were not fantastic. And that's part of the problem. Like, a lot of times they would say, let's implement this treatment, but never follow levels on anybody. So we don't even know what level somebody should be at for their estradiol or their testosterone or whatever in time to come, because nobody really followed that in the past. So it's a huge area that is open for evaluation. So residents, if you're listening, they could easily create studies for this for all of your senior projects. So.
Yeah. Now, you listen to Peter Attia, and so, he talks about...
I have a brain crush on him.
He talks about the old medicine where, you have diseases and you're trying to treat diseases, and then maybe kind of like a new type of medicine where you're trying to... People don't necessarily have diseases, but you're trying to optimize their life.
Right.
And this is a little bit more of that.
Right.
I mean, obviously, you're treating potential future diseases and things like that, but it's more of proactive, trying to make the quality of life and the length of life better.
Right.
And which is kind of a cool thing. And I think all doctors wish we could, or a lot of doctors wish we could kind of address some of these things. And so it's kind of a cool, very forward thinking.
It is. Yeah. I mean, for example, I had somebody that came in yesterday and she'd had a hysterectomy, but she still had her ovaries. She was, I think she's 52. And she's like, I don't know if I've gone through menopause, because she really doesn't have a lot of symptoms, but she's like, why would I want to be on estrogen? And so I kind of said, well, here's the health benefits of it. And so she was like, let's look. So I looked at her labs, and sure enough, she's in menopause. And so, I sent her the message, and she's going to come in and talk about, maybe starting on some transdermal estrogen. We'll talk about the risks associated with it, but also the longevity of what estrogen can do, though, is so beneficial for her health. And so we're going to have that discussion, though, too, instead of just saying, oh, you don't have any symptoms. Okay, bye. See you next year. So yeah.
It's kind of an exciting front. I do feel like, because it's this life optimization thing, you can also have, especially in men's health with hormone replacement. It kind of gets into this field where I don't want to say quackery. But the credibility with some practices is not the same as a doctor working in a hospital doing this.
Right.
And so it kind of gets in this gray area.
It's everything with hormones is in a gray area. And I do feel like it is the Wild West out there. And I can't even tell you how many people come in and they're like, even for women, though, too, it's not just for men. They'll go to these boutiques and they'll say, I'm on this and this and this. And I'm like, and I just kind of pause and I go, okay. And then, if they're feeling good and they're checking their labs and I think it's in the context of safety, I just let them go. But sometimes I go, I don't really agree with this, and I'll tell them why also, though, too. And they don't even understand why they're on certain things, though, too. And that's the bothersome thing, is that they don't know why they're taking this, or that. And sometimes I'm like, I don't know why you're on it.
But those places wouldn't exist if there weren't a market for that is not being met, with practitioners. Right. And so, kind of looking forward, my hope is that, reputable, practitioners can kind of fill in that market.
Right.
But
and it's hard, though, because it's time consuming. And unfortunately, in in medicine these days, it's very volume driven though too. Like you should be seeing this many patients each day in order to produce a profit though too. And it doesn't leave a lot of time to talk about all those important things. And that's where all of these other boutiques are coming in.
Yeah.
And that's where they're finding like, okay, people really do want this. I mean, from my standpoint for women, I mean, it's a combination of GLP-1s, testosterone, and then just general hormone replacement therapy. That is like a huge boom for all of these boutique practices right now because people want, and pellets. Pellets is like this other thing that's a huge money maker for people. And so physicians want easier lives and to be able to go in and charge a premium to see patients for see a certain small amount of patients for a huge amount of money is very, it's appealing though too.
Sure.
But that's where people are making it up as they go. I mean, we're all kind of making it up as we go because they don't teach this in residency and all of it's so new. We're all figuring it out together as we go. And I've definitely had clinical experience with different things where I'm like, okay, I could do this and this and this. And then, I can't follow somebody's levels well, and people are all over the place. And I decide I don't like it that way. Let's do it like this.
Yeah.
And it's talking to colleagues and seeing what they're doing. And I mean, I wish we had something in town where like we could, bounce things off of each other for what's working for them.
Like a consortium where you can.
Yes. Yeah. And that just doesn't exist.
And I don't want to, I don't know what goes on in any of these, like a boutique. I'm sure some of them are great.
Yeah.
But it just, it does kind of, I understand people, charging more for the time and the effort, and plenty of people are obviously happy to pay it.
Yeah.
And so it's not like anybody's being wronged.
Right.
But sometimes you just, I do think there's a credibility issue, and it's hard to say who's kind of more legitimate or not legitimate,
right?
Without throwing stones,
right.
But my expectation is in the next 10 years, some of this stuff will get sorted out.
Yeah,
whether it's through Google reviews or whatever.
Yeah, and I honestly don't even know. I mean, how long have pellets been out? Pellets have been out forever. There's no FDA. There's no FDA checks and balance system for any of that, not for supplements, so compounding pharmacies, like nothing. And even though I use reputable compounding pharmacies, I'm still always amazed that nobody is looking into like the products they're actually giving to people though too. And that's okay. The government says that that's okay, but I just don't understand it sometimes. I just don't get it,
Yeah.
I mean, one of my friends came to see me and she's like, oh, I want to be evaluated for hormones. And I drew her labs and her testosterone was through the roof. And I'm like, are you taking testosterone? She's like, no. And she's like, I mean, I'm taking this thing that I got somewhere and I don't even know where it was. Like she got it on like YouTube or something like that. And it was like DHEA, 100 milligrams, which converts to testosterone. Her testosterone was through the roof.
How about that?
But she doesn't know that. She doesn't know that her testosterone is going to be super high and she might start to have like side effects from it. And they could just get that over the counter.
Yeah, and there's a lot of supplements too that you can buy. And to be honest, like you kind of have no idea, especially for testosterone, guys lifting weights and stuff like that. You're hoping, it's like, oh, it seems like it's got 10,000 Google reviews and most of them seem good, because like guys were able to bench press more or something. And like you just go with it. It's kind of crazy. And it's not like they do clinical trials on these things. Like they're FDA approved, meaning it's like probably not going to kill you.
Right.
But it's not like a high standard.
Right. Well, it's even worse for women because we steal all of men's products for testosterone though too. We do. Because they won't approve anything for women, even though it's approved in Australia. In England, they won't approve a testosterone product for women. So we take men's and we take a fraction of what it is that men use, which is silly in itself. So once again, like we kind of have to resort to like, what are you doing? What are you doing? What are you doing to figure out how to actually to dose it for people though too.
So, for the audience, everybody knows that men, need testosterone or have testosterone. Why would a woman need testosterone?
So So women actually have 10 times more testosterone in their system than they do estrogen and progesterone. But nobody knows that because of how it's actually reported on labs. So like for women, testosterone, or for just in general, testosterone is reported in like nanograms per deciliter. And then for estrogen, it's reported in picograms. So it looks on paper like these things are the same, but they're very different as far as like the amount that we have. So women produce testosterone throughout their life, and then they have their peak, probably like mid 30s. It starts to come down a little bit after that then, and it continues to drop for us though also. And we feel bad when our testosterone drops also.
Yeah.
So our adrenal glands produce it, our ovaries produce it. But as it drops for us, then we start to feel the effects of it also. And the effects of low testosterone, is a couple different things. So if you have fatigue, and low libido is always one that people have, and that's there's a lot of different things that contribute to that, but low libido is a big issue. And then brain fog. Brain fog is a huge thing. That could be estrogen or it could be testosterone, though. So a lot of times when patients are telling me about what their symptoms are, we kind of go, okay, are you interested in testosterone? These are the different ways that you can do it also. This is how much it will cost if you go through compounding, if you use a gel that's prescribed by me, if you use shots, go through all that with them. Here's the side effects. You can grow potentially facial hair or acne. I would say whenever you think of like a 18-year-old boy with a great libido, but acne and a lot and facial hair, that potentially could be your side effect. And my goal is not to run people super high. Like I don't want to run people in the hundreds, but I usually will say somewhere between like 40 and 80 is like the sweet spot.
Pretty low. I mean,
it is. It's like where you'd be when you're 20 or 30 years old.
And
so
for reference, a man is going to have maybe between 200 and 800 roughly.
Right.
And so that's, you're probably very few people would grow facial hair, I would think.
Yeah. And if people do if they complain about a little bit of acne, then sometimes we'll give them spironolactone, which is what we just use in general for acne, for hormonal acne. So we just could give them a little bit of that to counteract it, though, too. But some of my patients do really, really well on testosterone, though, too. And sometimes they use it alone, or sometimes they'll use it in combination with things, though, too. I think the moral of the story is there's like a million different ways to do hormones, and just trying to figure out what is right for you is like, is what we're usually shooting for. And we don't always get it right the first time. Like we try this, and then we see what sticks. Like where do you feel good?
Okay. Now, how often do people have to get their blood checked typically?
Yeah. So I'll do it about every 3 months starting out until we figure out what your happy spot is. And then I'll just usually do it, for testosterone, we could only refill every 6 months. So we should check about every 6 months. Mm-hmm. But there's some people that have been on the same thing forever. And like, I don't even check them anymore though.
Okay. So, Now with, I know with like testosterone, like in general with men, I'm against them using exogenous testosterone until they're older, maybe like 65 or 70. That's just me personally. I'm not an expert in it. And because it's really hard if you have to come off of it, guys can have a really tough time, and it's cycled where you take it every so often. Is the hormones that you provide, are they cycled where you take them so often then go on break, or you go straight through?
We just go straight through.
Got you. And then how do people do if they have to come off them?
Well, I'm usually not part of that decision. They usually stop and then they come in a couple months later and go, I stopped my hormones. So, I mean, it's not a conversation people ever ask me is how do I come off of it?
Yeah.
They just decide like, well, you know what? I had this side effect. I didn't like how I felt on it. And then they just stop it.
How do they do?
On what, testosterone or anything?
Either one. Like when they come off, do they have a tough time?
Well, with the hot flashes, yes, for sure. For probably hot flashes more than anything else.
Yeah.
And that's a huge problem for women. Like 3 times today, I had women that were in their late 60s that came in. They were like, I'm having problems with hot flashes again, though, too. So we know that like when you take people off of it, you could go back to that same state of like, look, you're newly postmenopausal again, though, too. So it can It can drop.
Yeah, I see patients who end up having estrogen positive breast cancer, and so they have to come off the supplementation. And it's the hot flashes and the vaginal dryness seem to be like the two big ones.
Yeah.
And they do not like it. I mean, it's
right.
tough.
Yeah. There is Veoza though. So I love Veoza now for the appropriate candidate for people that can't have estrogen anymore.
And what's Veoza?
Veoza is now, it's a medicine that's out that you take orally daily that basically resets how your body interprets heat so you don't have the hot flashes anymore. I think it works in the hypothalamus, but it's totally non-hormonal, so that's very appealing to people, and it works well. The caveat is that you have to have your liver function checked though too. So like at 3 months, 6 months to make sure that it's not affecting your liver. So that scares a lot of people off. But my patients that have been on it that have always had normal liver function, it's worked really, really well for them though too. So
that's great.
It's definitely something. So.
Yeah, the hot flashes are a big deal. And when I see men for prostate cancer, if it's advanced, they have to have a testosterone blocker.
Yeah.
And when I'm telling the men, these are going to be the side effects of the testosterone blocker, the two main ones are hot flashes and then they have zero libido.
Yeah. Can men use Veoza then too?
And so I don't know. I mean, it's probably worth trying. Yeah. But the hot flashes are short lived because they're usually not on the androgen deprivation. I mean, sometimes it's 6 months, sometimes it's 2 years. Every single time. You feel the hot flashes aren't good. We can all agree on that. Every single time I tell them they're going to have the hot flashes, their wife laughs at them. And I just feel like that's me.
Welcome to my world.
I feel like, there's no sympathy. You would think they would have sympathy, but no, it's like, it's like they're gleeful. And so
that's like when dads have to go get their vasectomies and they're like, oh, woe is me. I'm like, did you just see what your wife went through? Like, cry me a river.
Well, Julie, I really appreciate you. We've had many mutual patients over the years. And so thank you for coming in. I think this is going to be a really popular episode, and I think a lot of people will be interested in it.
Yeah. If you want anything more, if you want to talk about anything in the future, just let me know. I'll be happy to. I feel very comfortable doing this.
And how would people get a hold of you? Do you have a number?
My office number is 314-205-6788, and I'm at St. Luke's, and I'm on the St. Luke's website, though,
awesome.
too. So,
thanks so much, Julie.
Thanks.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.